problem is actually quite fundamental. Across Canada and across the world, there is no standard of care. And in fact, there's no data to suggest that any particular model is advantageous when it comes to evaluating the patient with a first seizure and a patient at risk of epilepsy. And so that's what makes the single seizure clinic quite unique. What our attempt was with this model was really a proof of concept to show that, you have a patient who experiences their first seizure. What happens when you link them up with an epilepsy expert at that first contact? So previously in Canada, patients would often go through multiple emergency room visits, multiple primary care visits, multiple neurology visits before they could get the appropriate investigations in order. And what we were hoping to set up was a very simplified platform that was easily accessible to all patients and all physicians, and then they could refer the patient to an epilepsy specialist who could then take charge of the patient's care, determine if they are having seizures, determine if they have a diagnosis of epilepsy, and really do that under one umbrella. And so that really is what makes the single seizure clinic unique. Particularly what we were hoping to accomplish was to make the diagnosis of epilepsy quicker, identify patients who are at risk to themselves and to others of having other seizures, and to get their care organized in a deliberate, timely manner, which is really the fundamental issue when it comes to caring with patients with epilepsy. So that's really what makes this model quite unique. As part of the study, we were very heartened to find that we achieved wait time reductions across the board. So when you're looking at assessment investigations, we achieved wait time reductions ranging from 50 to 90%. So for instance, with the single seizure clinic model, a patient was seen within about 24 days from event onset, whereas previously the wait time was about 80 days. That's a 71% reduction. On average, we could do an EEG within 4 days from the time of event onset versus our historical average of almost a month, and that represented about a 90% drop in wait time. Similarly, other investigations could be done much, much quicker. So patients certainly benefit. They have less uncertainty. We get to order the investigations we want, and we're doing that much quicker than we were in the past. Certainly we think the single seizure clinic puts patients first. The diagnosis of epilepsy carries tremendous implications for the individual, for their health and their social status. Anytime you bring up the possibility of seizures and epilepsy, you're talking about driving restrictions, you may be talking about stigma, you may be talking about cultural issues. You're touching on really a patient's sense of independence and a multitude of economic issues. It's important to identify patients who have epilepsy and also to identify patients who don't have epilepsy, because the treatments are quite different. Epilepsy is eminently treatable, and really who better to make the diagnosis than someone who's worked in the field. So what this does is it ensures that patients get the necessary investigations they need while avoiding unnecessary stress and avoiding mislabeling, avoiding misdiagnosis, and avoiding unnecessary investigations. So in that sense, it's very reassuring for the patient and for the referring clinician. So I think what we've done with this study is we've shown in a prospective fashion that a single seizure clinic is advantageous. It reduces wait times. We found that we can appropriately triage patients. We can do this in a large, practical academic setting with really a minimum of resources. There are future areas we would like to investigate, including how this impacts patients' overall health outcomes, how it affects cost effectiveness, how this affects healthcare process flow. Additionally, we were also able to show that you really do need epilepsy specialists in charge of the care who are physicians. As a second part of the study, we looked at the diagnostic correlation between our epilepsy care nurses and our epileptologists, and we found there was only a modest diagnostic correlation between the two, and this diverges a little bit from what was suggested in prior literature. So we think an epilepsy single seizure clinic under the purview of a physician who specializes in epilepsy can be quite beneficial to the patient, and we believe that it can reduce some of the inpatient demands that these patients may present.